suffering. And I'm going to follow on with our protocol for NIV in the respiratory ward. And it is very important that everyone's aware of this, because when you're on call, it's important to know what the policy is. And if you're on call and you're called to bed ward and there's a patient on a ventilator, it is really important to know how to look after them. We ran a simulation session yesterday to practice the problems that patients often experience on ventilators. And it's important that everyone on the on-call team is aware of that and what to do. It gives you all confidence and helps the patients and the nurses. So we're going to start off today with Dr. Merritt's protocol that's been devised. You've probably seen this from April. It's been changed slightly since the last time we presented this. And you can see that if you think a patient has COVID, for example, if they've come in with high temperature, breathlessness, then please obviously get their X-ray early and blood gases. And the criteria for severe COVID is saturations less than 94 on 10 litres and a respiratory rate greater than 30. And if they don't meet those criteria, then they need to be re-evaluated every 6 hours. So that's why we have the nerve centre to help us with that. Obviously, anyone who's got severe COVID needs to be considered for all treatments available. So we need you to look at their mobility before admission and involve the respiratory consultants on call. We have an on-call rota running 7 days a week, 24 hours a day, and the ITU team to decide, what their escalation policy will be. And if they're for full escalation and they meet the criteria for severe COVID, then they'll go to ITU. And as you know from the research trials, dexamethasone and remdesivir is considered for those patients who require oxygen and meet the criteria for severe COVID. Now, if they don't meet the criteria for ITU admission, they'll be considered either for ward-based care, and they may not necessarily receive anything more than the basics of oxygen, dexamethasone, and remdesivir. But if we think we can help them on the respiratory ward with CPAP, then we'll be starting that inside room 1, which is a negative pressure room, on bed red. And we'll start with 7 centimetres of CPAP and then train 10 litres of oxygen. And we'll be looking to see if they improve their respiratory rate, their oxygen saturations, and we'll be monitoring them quite carefully. Now, we would like everyone to consider a blood gas at the beginning of their treatment in ITU, because if they're COPD and then they're in type 2 respiratory failure, then they'll need BiPAP rather than CPAP. And this is the end of the protocol. It shows that we re-evaluate those patients who are on CPAP or BiPAP every 30 minutes. And if they're improving, then we can think about weaning them from NIV. We tend to wean patients in the daytimes. We give them time off the ventilator to have meals and physiotherapy. And when they're off CPAP for over 24 hours and they're on less oxygen, they probably won't need the negative pressure room anymore. Now, if they're not improving, our protocol has now changed, so we'll be increasing the CPAP pressures, and we'll be trying to get the patients to prone to lie on their front. And that's been shown on research studies to help recruit parts of the lung that are affected, particularly at the bases of the lung. We can't move the patient ourselves, so that patients have to be fit enough to turn in the bed themselves. Now, I've mentioned there some drugs that we give in COVID. We give dexamethasone and remdesivir. We participated in the recovery trial, which was to look at what type of treatments will be available. And Osei is now going to go through what's been considered to be effective treatment and what we'll be providing here at Conquest. So over to you, Osei. Can you hear
that? Yes, I can. Hello?
Yeah, we can hear you.
Yeah, okay, right. Okay, I'm sorry. So we were one of the first hospitals to participate in the recovery trial, which is a UK-wide trial looking for evidence-based to support the decision-making in the management of COVID patients. The recovery trial initially had a lot of medications, including interferon, dexamethasone, azithromycin, usual care, and those were the initial medications. Some of them have been stopped. Lopinavir, which is an antiviral agent, were the initial ones. Lopinavir was noted not to be effective and probably causing harm, so that arm of the trial was stopped very early. The initial results from the recovery trial showed us that dexamethasone reduced death rate in people who were particularly unwell. And so that has been adopted as standard therapy in anybody with COVID requiring oxygen. This trial is, I'm just flagging it up to say that if we admit somebody with confirmed COVID, then somebody has to document that the patient needs to be considered for enrollment in the trial, because the more patients we get, the more knowledge we gain about how best to manage our COVID patients. So far in the UK, 12,000 patients have been recruited and the recruitment is ongoing. Currently, when we recruit patients, the first part of the randomization is to azithromycin or no additional treatment. And then automatically it also enrolls them into no additional treatment, recently introduced neutralizing antibodies, which are available in some trusts, and also convalescent plasma, which has been obtained from people who have recovered from COVID in some trusts. So these are the two types of COVID recovery treatments that are being delivered at the moment. We haven't so far had anybody randomized to convalescent plasma. There's a second part of the randomization, which is if you have COVID, you're on standard treatment, and then you become more unwell with the so-called inflammatory response, heading to intensive care or already in intensive care, you can be randomized again, which is called the second randomization for tocilizumab, which is an anti-inflammatory agent. So far, those are the trials that are available in this trust, and we're encouraged to think about this for our patients. So if you can't randomize, you can always ask for somebody who can randomize. The recovery trial has a website which is very self-explanatory, and if you're interested in randomizing patients, you undergo your training. Once you get your confirmatory email, send it to the research team, and they'll put you down as one of the randomizers. And for trainee doctors, that counts as your part of your audit stroke quality improvement and stroke research in your portfolio. This is the therapy of COVID. We also have the respiratory arm of the COVID trial, and patient can be randomized in both of them. RS stands for respiratory support, and CPAP, which Dr. Christopherson is going to talk about, standard oxygen therapy, which is what we all use, and high flow nasal oxygen is delivering oxygen with a nasal mask at greater than 90%. We don't use it in this trust often, so it's not part of what we would normally offer a patient. But then what the trial is trying to see is that in patients who are oxygen dependent with SARS of greater than 94 or more than 10 liters, which of these are the most effective in terms of outcomes? So that's what the respiratory recovery RS trial is looking at. The one proviso for this trial is that the patient should have been seen by critical care colleagues and accepted for transfer to critical care if they become less well on the treatment. And so for patients who are deemed palliative, they will not be eligible for this trial. So that's what's ongoing at the moment. We've talked about dexamethasone in terms of therapy. With remdesivir, there is some evidence from a trial published in the Lancet, which was an international trial, which showed that it probably reduces the length to which people recover, and probably reduces viral replication. And that is why it's been accepted for use in the UK, but it's not part of a trial currently. So, but it's available to use, and the NHS has supplied trusts with various doses, sufficient doses to use if necessary. But whenever it is prescribed, a pharmacist needs to be informed straight away so that they can fill something called a blue tech form, because it's using medications outside their license, and then it will be supplied to you because it's NHS approved. So I'll hand back to Thereza for her to carry on with the rest of the talk.
Thank you, Osei. Okay. So the rest of the presentation is what you'll need to know about providing non-invasive ventilation. Our on-call service, consultant on-call service is it's 24 hours a day, 7 days a week, but we won't be available to come in at night. So the on-call doctors in training will need to know how to look after patients on NIV. We ran simulation sessions yesterday with certificates of attendance. We will be running more in the future. So it is very important to attend these to get practice on and be comfortable on looking after these type of patients. So we're just going to talk about what non-invasive ventilation is. It's providing ventilation support through the patient's upper airway using a face mask. And it's provided on the respiratory ward and HDU. It's different to invasive ventilation, which requires either a tracheostomy or an endotracheal tube. And at that point, the patient doesn't have control of their airway, and the treatment needs to be provided on intensive care. Now, we're going to be talking about when we use non-invasive ventilation, what respiratory failure is, the indications, contraindications, the things that you'll need to think about before starting it. And then importantly, the problems you might experience when you're on call looking after a patient on an IV and how to correct them. So starting off, what is respiratory failure? Why do we need to use non-invasive ventilation? Well, it's defined by the blood gas, and you all know the normal blood gas settings. So pH of 7.35 to 4.5, PO2 greater than 10, a CO2 between 4.7 and 6, and normal bicarbonate. And type 1 respiratory failure is simply a lack of oxygen. So the pH is normal, the CO2 is normal, but the PO2 is less than 10. And we're expecting a lot of patients to come in with COVID-19 viral pneumonitis causing this type 1 or hypoxic respiratory failure. But other causes are asthma, pulmonary embolism, and pulmonary edema. Type 2 respiratory failure can either be acute or it can be acute on chronic. If it's acute, the pH will be low, less than 7.35, and the CO2 will be greater than 6, but the bicarbonate will be normal. If it's been going on for a long time, the kidneys compensate by the bicarbonate rising above 30. And in both cases, the oxygen levels are less than 10. So what are the causes of type 2? Well, the commonest cause is a COPD exacerbation, severe disease, but anything also that causes diaphragm weakness, for example, C345 injuries or neuromuscular disease can cause type 2 respiratory failure by causing a weakness of the diaphragm, particularly during deep sleep when we rely on the diaphragm to breathe. Be aware of it in patients over a BMI of 35. It's increasingly common in patients who have morbid obesity and those who are on excessive opioids. So what is NIV? NIV means non-invasive ventilation, and there are two different types. There's the CPAP, or continuous positive airway pressure, provided through a face mask, and BiPAP, or bilevel positive airway pressure, provided also through a face mask. The CPAP is the same pressure throughout inspiration and expiration, and it forces the tongue out of the way, so it's very helpful for sleep apnea, but it also pushes anything in the alveoli out of the way. So if the patient has pulmonary edema, it's very effective in improving oxygen levels. And in COVID, it's particularly helpful in those patients who've got that viral pneumonitis affecting their alveoli. So we use it to improve oxygenation, and it's used particularly in the home setting for obstructive sleep apnea. It's indicated only in type 1 respiratory failure, and we use it on the respiratory ward or HDU. If a patient comes in from home with their CPAP machine, unfortunately, they can't use it on the main hospital, and we'll be going into the reasons for that later because it is an aerosolizing procedure and potentially can transmit COVID if they don't know they have it. BiPAP is bi-level ventilation, and it's used for type 2 respiratory failure, so when there's a lack of oxygen and a failure of ventilation. And it provides this ventilation through both cycles of the breathing cycle. So IPAP is the inspiratory positive airway pressure that boosts the patient's tidal volume as they take a deep breath in. The ventilator will give the patient a sort of support to every breath they take. And the expiratory pressure is the pressure they feel as they breathe out. So there's always some air being pushed into the back of the throat and into the alveoli, forcing the alveoli open and improving oxygenation. And but the difference between the two, the IPAP and the EPAP, is the tidal volume. Now, if you want to improve oxygenation, obviously EPAP is the one to increase. It forces air into the alveoli and pushes the tongue out of the way. It's not continuous as in CPAP, it just occurs when the patient's breathing out. IPAP is the pressure that we use to remove carbon dioxide. So that's what we increase if the carbon dioxide level is high. And if ever you think that you want to improve the EPAP or improve oxygenation, remember that if you increase the EPAP by 2 centimeters, you'll have to increase the IPAP by the same amount in order to maintain the same tidal volume. So in summary, the IPAP is there to improve tidal volume. It gets rid of carbon dioxide and it reduces the work of breathing, whereas EPAP forces air into the alveoli, improves gas exchange, and improves the dynamics of the lung. So what are the indications for BiPAP? Well, as I said, it's predominantly used in sleep and COPD, but we're finding a lot of people with COPD have obesity problems as well. So there's actually an overlap between obesity, hyperventilation now, and COPD. And the other causes are predominantly due to diaphragm weakness. And in all of those cases, the IPAP improves gas exchange and the EPAP improves oxygenation. There's been a lot of recent studies now showing that home mechanical ventilation can actually improve patients' quality of life and reduce readmission in COPD. And this is the study that's looked at that in the last couple of years. And they recruited patients who came into hospital with type 2 respiratory failure due to COPD to either receiving home oxygen or home oxygen plus a mechanical ventilator. And they looked at the main outcome of being admission-free survival. And they found that those who received a ventilator, who had been discharged from hospital with type 2 respiratory failure, it took them almost a year to be readmitted compared to only a couple of less than a month in those that just received oxygen. And during the COVID pandemic, we particularly want our patients with COPD to be at home in the community where they're safe and not coming into hospital every month with type 2 respiratory failure due to COPD, because their risk of contracting COVID in a hospital is quite high. So we've talked about the indications for NIV. We're now going to talk about when you shouldn't use it. And we can't use non-invasive ventilation when the patient's GCS is low. So when the GCS is less than 8, they can't protect their upper airway. And if they vomit and they're unconscious, they can't remove the BiPAP or CPAP, and there's a higher risk of aspiration. So if anyone comes in and they're really drowsy and the GCS is less than 8, they need to go automatically to intensive care for intubation if that's appropriate. If they've got facial injury or burns to the face, obviously a tight face mask for NIV is not suitable. And if they've been vomiting or have got any signs of obstruction of the bowel, NIV isn't appropriate either. We don't use NIV in an untreated pneumothorax, as the pressure from the ventilator will make this worse. However, once the pneumothorax has been treated and the chest drain is in place, it's quite safe to go ahead and use it. And in this trust, we're not using NIV in patients who can't consent or collaborate with the nursing staff for NIV. So patients who are very confused or have dementia, we don't give NIV to, because it's very frightening for them. And if they can't comply with the treatment and work with the nursing care, it just increases risk. So the things we'd like you to consider before starting NIV is, please follow the trust protocol that we went through. Do the blood gases and assess whether they're in type 1 or type 2. Please ring the respiratory consultant on call. We're on call 24 hours a day, 7 days a week, and switchboard have got our numbers. Please ring ITU as well and try and make a decision of whether you think that patient would be suitable for invasive ventilation. And between us, we'll decide if they should go straight to ITU or to the respiratory ward for NIV, and what we'll do if the NIV fails, whether they'll be intubated or they'll receive palliative care. And remember, if they've got an underlying condition like COPD, it's really important to treat that with the standard therapy of nebulizers and steroids, because the ventilator itself doesn't correct COPD, it just supports the patient. And nebulizers can be given through the NIV circuit. They don't need to be, the machine doesn't need to be taken off just for a nebulizer, so you can prescribe that. Please ring our site practitioner, and she will help us move the patient to the respiratory ward. And we're doing all our CPAP in side room 1, which is our negative pressure room. It sucks all of the air out of the room, and it helps prevent contamination of the whole ward. Our staff looking after patients on NIV will be wearing full PPE. So instead of the standard surgical face mask, they'll be wearing an FFP3 face mask to protect them. They'll be wearing visors, full gown, gloves, and shoe covers, and we've got hats now we wear as well, so hair covers. And this is the protocol we have for our ward. So we're very careful about where we move our patients, because we don't want to do, if possible, we don't want to do NIV if it's not inside room 1, because once we move into doing CPAP or BiPAP outside the negative pressure room, the whole ward will be contaminated by aerosolizing COVID. So everyone on the ward will need to wear full PPE. It won't be just the nurse dealing with side room 1. And we can't have any triage patients in A bay or B bay. So that's the reason why we particularly want you to call us if you think someone needs CPAP. We aim to keep side room 1 empty all of the time, so that if you need a patient to start CPAP quickly, there's always access. As I said, in our Conquest, we'll be doing the procedure on Baird Ward and HGU, and over at Eastbourne, it'll be Jevington and HGU. As I said earlier, the circuit that we're using for BiPAP and CPAP is different to the circuit that patients use at home. And this is what we'll be using on the ward. You can see it's a full face mask. It's got 3 ports where the oxygen can go in. And it's got this yellow filter that filters out any viral particles the patient's breathing out. And the expiratory port, where the carbon dioxide comes out, is below the viral filter. So it keeps everyone as safe as possible. And we ask our patients and our nursing staff to turn off the ventilator before they take off the face mask to try and reduce contamination. If the mask I've shown you isn't comfortable for the patient, we do have access to these COVID hoods, which take the pressure off the face a little bit more, and some patients prefer them. However, what we won't be using is the patient's home masks. These are the masks that they use for CPAP in the community for sleep apnea, and you can see they're very different. The expiratory port for these masks is right on the front of the mask, so it doesn't give any protection to the staff around. Anything the patient breathes out will come directly out into the environment and contaminate the ward. So I'm afraid if your patient comes in with a CPAP machine and they want to use it on MacDonald or Newington, they can't, I'm afraid. And it's really important as the on-call team, you're clear with them that they can't use their CPAP in a hospital environment until all their tests are confirmed negative. And even if they are negative, I think the policy here is not to use them unless they're on Baird Ward. The other filters that we use are at the end of the ventilator circuit to protect the machine, and they're single use only. We'll be running the CPAP at 10 litres of oxygen with a pressure of 7, and we'll increase it to 10 and then 15. And if the patient's in type 2 respiratory failure, we'll be using BiPAP with a starting pressure of 16 centimetres of water and NEPAP of 6. We're aiming for SATs of 90%. Please do document the consultant you speak to on call, the settings that they recommend for the machines, and the oxygen flow rate, and of course your blood gases. This is the ventilator that we're using on Baird Ward. It's a ResMed ventilator, and it can do CPAP or BiPAP. Now, I've created a YouTube training video on the settings. We ran through them yesterday at our simulation session, but if anyone can't come to simulation, you can look up the YouTube on the Trust intranet site. You simply type in COVID into the A to Z search, and then go to education and training, and you'll see the training videos there, and I'll show you them in a moment. So that ventilator can do spontaneous breathing, so it can do CPAP or BiPAP support. It's also clever enough to take over the patient's breathing if they're under anaesthetic and they require timed ventilation. I've tried to take a snapshot of our Trust intranet page where you can find the training videos. It's under medicine, respiratory medicine, and non-invasive ventilation under COVID-19 education resources. And there's 3 presentations, NIV, NIV patient demonstration, and then all about the ventilator and how you change the settings on the ventilator. The standard CPAP machine that patients use at home looks like this, so it looks slightly different, and that only does CPAP. And the safety features on our ventilators are that they do alarm if there's high pressure or there's a leak, and our nurses are doing checks every hour to make sure that the expiratory port doesn't become blocked. So when we start off NIV, we will be spending quite a lot of time with the patient to explain the benefits that it's going to give them. The research shows that patients who start CPAP early tend to have a better hospital outcome than those started very late. And that's what we found in our audit in April and May. All those patients who got CPAP quickly within 12 hours of admission tended to survive, whereas the ones who unfortunately didn't get CPAP early and didn't do so well. So we would like you to call us early and explain the benefits to the patient when you start the CPAP. It is important to advise the patient that if they feel sick on the ventilator, they need to call the nurses to remove it. We teach them how to take on and off the face mask at the initial setting. And when we start off the NIV, we show the patient the face mask, allow them to put it on themselves, ensure that we've removed any leaks. And if, unfortunately, some patients just can't tolerate it, we will need to consider a plan B. And for patients who are for full escalation, that will be going to intensive care for intubation. And for those who are not, we may need to just consider palliation or just standard treatment. We can actually do NIV with dentures. It actually helps the mask fit, so we don't need to remove them to do NIV. We're now going to go through some problems that you might be called about if you're on call and you're called to see a patient on the NIV ward. The main problem you might get is a patient waking up in the middle of the night and not realizing what's going on and forgetting that they're on NIV and becoming quite distressed. Now, our nursing staff have been trained how to deal with this. They'll turn off the ventilator and they'll remove the mask, and they won't reapply it until the patient consents to do so. However, if there's an agency nurse there and you're called, remember you will need to put on all of the PPE before you go in the room. And if the patient's very anxious, obviously that takes time. So all you need to do is give clear instructions to the nurse. We've got a nice big glass window on side room 1, so it's very easy just to knock on the window and give them clear instructions. And the instruction is just to stop the ventilator and remove the mask. And the same applies to if the patient's feeling sick. You need to advise the nurse to stop the ventilator, remove the mask, and then when you've put all the PPE on, please do examine them and find out why they're feeling sick. If they've swallowed a lot of air, for example, it may need to be off the ventilator for some time to recover. And if they've got a bowel problem, unfortunately, we can't restart NIV until that problem has been resolved. If their oxygen levels are low and you're called to the ward, obviously put on all of the PPE first and then look for any mask leak. There is always a small risk of pneumothorax if the pressures are high, and in that situation you will have to ask the nurse to turn off the ventilator and remove the mask and obviously get an x-ray and see if you think there's a pneumothorax there that needs treatment. If you don't see any clinical indication for a pneumothorax, then the next step would be to increase oxygen and increase the EPAP if they're on bi-level ventilation, and if they're on CPAP, to put it up to the next step, which will be from 7 to 10 to 15. And please ring the respiratory consultant on call. That's what we're here for. Now, if the patient's got a high CO2, for example, if they've got COVID and COPD or just COPD, steps we'd like you to take is, first of all, put on the full PPE and have a look at them and see whether the expiratory port on the mask is blocked. The nurse should be checking this every hour, so they should be able to have picked up that problem already. check the viral filter, and that again should be changed every 24 hours, and check for mask leak. Have a listen to the patient's chest. If they hadn't had their nebulizers and they're wheezy, restart that. And if you've checked everything else and the CO2 is still high, then you can increase the IPAP by 2 centimeters. And remember to repeat the blood gas in an hour and to inform the respiratory consultant on call. Other problems you might experience is obviously patients can't eat and drink when they're on NIV, so they will need IV fluids prescribed. And sometimes they swallow some of the air, and if they feel a bit full, sometimes we'll have to reduce the pressures or consider an NG. And pneumothorax is a medical emergency on NIV, and it happens very, very rarely, but it's the kind of thing you don't want to miss. If a pneumothorax occurs, it generally is in a very small patient who has severe emphysema, who develops a bulla, and the IPAP pressures are too high and cause a pneumothorax. They will generally present with acute shortness of breath and chest pain on the ventilator. And when you examine them, you'll hear no air entry on one side, and the trachea will be deviated to the opposite side. That's considered a medical emergency, and it's really important to stop the ventilator, put on the oxygen, and prepare to decompress the pneumothorax. So examination is important at any step during the care of these patients, and repeating blood gases. Now, our nurses also will be doing a number of checks on the patients. Following our experience in April and May of COVID patients and NIV, we've put together this checklist for our nurses to make sure a lot of the problems are actually dealt with and they don't need to call a doctor. So every hour they'll be checking the oxygen ports are used correctly, the filters replaced if necessary, and that the expiratory port isn't blocked. They'll make sure the patient's got access to a call bell and obviously is consenting to treatment. Now, we'll be weaning the patients from ventilators when we feel that they're stable, so they need to be stable for at least 12 hours. And we'll be doing the weaning during the day, so we'll give them time off the ventilator to have their meals and physiotherapy, but we'll be encouraging them to use it at night because that's when it does most of its benefit to their recovery during sleep. And then we'll be monitoring them very carefully as they come off the ventilator because there's always the risk they can deteriorate. And for those patients who come in with a type 2 respiratory failure due to COPD, we'll be trying to get them on home mechanical ventilators to try and keep them out of hospital as much as possible during the COVID pandemic and afterwards. So in summary, we've talked a little bit about COVID, the new protocol, and the indications for NIV and the problems that you might experience on call and how to safely apply it. Now, do we have any questions from anyone about either the treatments or anything about the bed policy or anything at all?
Thank you, Thereza. That was really wonderful. That was really clear and it's very straightforward for everyone. I've been looking at the message groups. You must have been so clear that no one's actually come up with a direct question yet. But I'm sure they will at some point. Maybe to start it off, I probably had a bit of a question. Mainly, I guess, around at night. Is there a specific rank of doctor you think would want to would be the one you want to get a call from? As in, in GI bleeds on calls, we used to put the stipulation that it would ideally have to be the registrar. But do you think really that doesn't really apply in this setting with these cases?
Well, the registrars are obviously changing very soon, so we'll run a simulation session for them. But I think anyone who's attended our simulation training would be happy to take calls from them. One of the on-call team did very well recently. We had a patient on side room 1 who needed BiPAP and their CO2 was high, and they went through all the checks as we did in the simulation training, and they corrected the problem very nicely. So I think we're happy to receive calls from anyone who's done the training and has been to see the patient. We do want to hear from you if you've got a problem with a patient.
I think that's the key. It's the training, isn't it?
Yeah.
We've got Dr. Nahas who had some questions. Dr. Nahas, I don't know if you want to unmute and ask the questions you have. We've got a few.
Yeah, thank you for that. That's really good talk. I don't know if this is beyond the scope of what you're talking about, but I wanted to just ask you a bit about treat as positive patients.
Yes.
Is that okay? So I've noticed that the pathway for the respiratory care it starts off, the first box is probable COVID-19 patients. Obviously, we're not going to have a swab result initially as they present. So do we start those patients with suspected COVID on straight away in Dex and remdesivir? Would you rather wait for the COVID swab first to be positive?
So if they are severe, meaning they're on 10 litres of oxygen and really high respiratory rate, then clearly they meet the criteria for those treatments. But you'll have to get your X-ray and you'll have to have some clinical evidence of COVID. And I think, if we've got a lot of clinical evidence, then the team will probably, the ITU team will, and our respiratory consultants were likely to say, yes, start the treatment. We can always stop it if we find it's something else. But if it looks like COVID and they're severe, they present needing oxygen, then the trial evidence shows that, yeah, they should receive it as soon as they can. For those patients who've come in with, a little bit of cough and you don't really know what it is, then they don't need those treatments until they meet the criteria. These research studies are very clear. They have to be on oxygen to qualify for dexamethasone and remdesivir.
Thanks,
so at
Thereza.
the moment, there's no one. So if you look at the patients on bed, well, there's no one who meets criteria at the moment. So.
Yeah,
That's
and I just have a couple of more. Do you mind if I ask a couple of more questions?
Go ahead.
Sorry.
Now's the time to ask.
So there was I don't know if you're aware of this, but there was an audit carried out by the AMU team here in Eastbourne, and they looked at March to June period, looking at the basically false negative rates of the COVID tests. They did 102 patients, and approximately 24% of those patients who ended up eventually testing as positive initially tested as negative. And then, we're heading into a winter season soon, and I think there's some concern about whether we're going to have a bad flu season on top of possibly a bad COVID season. And reviewing the treat as positive guidance at the moment, anyone with an influenza illness ticks the box. So, are there any sort of plans to review treat as positive guidelines? And in the meantime, we don't have a lot of patients. So should TAPs be reviewed by all TAPs be reviewed by respiratory to see if they agree or not, whether it's a TAP? And are these going to be, reviewed, these guidelines?
Quite a lot of questions in this.
Yeah, but that's what everyone is
May
saying.
I contribute to the answer, please? This is Osei Kankam.
You go ahead first, Osei.
Guidelines are being reviewed, and I think Dr. Merritt is leading a clinical group for this review. So I think it will provide us a lot more clarity going forward. With respect to getting a respiratory physician to review every patient with suspected treated positive, that is not feasible and that's not likely to happen.
I think it'd be quite unrealistic.
With our revised criteria and based on our revised criteria and clinical judgment by the senior attending physician whenever possible, I think that will go a long way to helping us making our timely decisions about how best to manage these group of patients. But I accept your concerns about false negative patients, and it's always, as you know, it's always a clinical judgment about repeating tests on these patients.
Thank you, Osei. I think Dr. Merritt might have had might be saying something as well. Simon's posted a few things, but Simon, do you want to say anything verbally, or if not, I'll just read out your messages.
I missed some of the question. I do apologise. I posted and I had to dash out and came back again. My concern with the treaters positives is that we are massively overcalling them, massively overcalling them. And we're therefore bunging up, for want of a better term, our red areas. And although the prevalence has been of COVID has been higher, documented prevalence has been higher in Eastbourne, the sheer number of treated positive patients that have been coming through Eastbourne as well just doesn't match with the expected prevalence. And when I did an audit, which was midway through the pandemic, it suggested between 35 and 40% of what we were calling TAPs did not fulfill any criteria. The difficult thing, though, obviously, is a lot of people can have no symptoms from COVID at all, but there's nothing we can do to pick those up, except that the plan is, and this is, when I say a plan, an intention is for us to be moving towards 24/7 testing. It's not possible yet, and probably won't be for another couple of months. depends on recruiting technicians, etc. But certainly our winter plan will involve doing that, and that test will be a single swab that will look at for influenza A, B, H1N1, and also COVID as well. I will be quiet now.
Thank you, Simon. That's really helpful.
Thanks.
I've got a few more questions on the group. Prahan's asking, this one might be for you, Thereza. How does one book for NIV training?
So we ran 2 sessions yesterday. It's a shame you didn't come because everyone received an invite from the education team. It was run from 1 until 3 and then 3 till 5. If you would like to receive some training, some simulation training, please could you let the education team know? So contact Anita and she'll let me know, and then we'll create another one that everyone can come to. But we can't really run sessions just for 2 people. You know, consultant time is precious, and we can't run a whole afternoon again if we only get a few people. So once we got 10 doctors, we'll run it again. And remember, you can go onto the Trust website, onto the Trust intranet site, and look through my YouTube videos, and they're very explanatory and make sure exactly what you need to do. But please contact Anita and let her know that you want training, and I'll run some more sessions. That's
great, thank you. Dr. Deshoras had a question. I think maybe Osei, you can answer this. Do we have plasma treatment at Conquest? I have a feeling the answer is no, but Osei, what's the answer for that? Oh, sorry, Osei, you might be on mute. Hello? Oh, he might be gone already.
Well, we don't have treatment as far as I know. Yeah, we don't have plasma treatment yet.
Fair enough. Okay, I think that's the only questions I've had so far, unless anyone else has a question. No, I don't think anyone else is coming up. But thank you very much for that, Thereza.
You're welcome.
Oh, I think Osei is on there now.
Oh, sorry.
That's okay.
Was that question I missed? I'm sorry.
Oh, it was just whether we have plasma treatment, but we I think Thereza.
Oh yes, I left the room temporarily. We have been approved. The trust has received approval for the use of convalescent plasma, but it's strictly within the context of the recovery trial. And as I said, the recovery trial has 2 randomizations. So you do the first one, it's usually either azithromycin or standard care, which we are given anyway, and then the software automatically randomizes the patient again to receive either usual care, convalescent plasma, or the antibody. We don't have the antibody available. We have some convalescent plasma. But in order for a doctor to prescribe that, you should have done the randomization trial for the plasma, which, yes. And then the plasma, I think the system at the moment is anybody who is randomized to it is doing 1 to 1 to 1 to 1 according to the computer system that is used. So I don't anticipate that we'll get a lot of people being randomized to receive convalescent plasma. But yes, it is available for the right patient when they are randomized in the recovery trial. But outside of the recovery trial, we are not allowed to use it.
Understood. Thank you very much.
In other words, it's available, but only on probably ITU or on the respiratory ward, not A&E. It's not the kind of thing they'll get in A&E.
It's not a standard of care or anything like that, really. Okay. Well, thank you very much, everyone. I think the take-home messages from me is definitely be aware of the COVID guidelines for our trust. Learn about NIV and make sure you get the appropriate training, because you'll probably need to assess patients, and to be familiar about the research trials also ongoing for COVID. So I want to thank all the speakers today and everyone else who's been able to attend. We will edit the recording appropriately, and when the time is right, we'll put it onto a website for you to be able to access in the future for grand rounds. Apart from that, I'm very grateful to everyone. Thank you very much.
Okay, thank you. Bye-bye.